Today, we're going to explore stroke as a health condition and our role as health social workers in stroke care. We're going to be looking at understanding stroke's impact, health disparities, and interventions at all levels of social work practice. Let's start with understanding what a stroke is. According to the CDC, strokes happen when the blood supply to part of your brain is blocked, that's an ischemic stroke, or if a vessel in the brain bursts, that's a hemorrhagic stroke. This harm to the brain can result in lasting brain damage, disability, or it could even be fatal. Statistically, Tsao et al. Found that every year about 795,000 people in the United States has a stroke. That's every 40 seconds. And the global burden of disease statistics in this slide are even more staggering. What's particularly important for us as social workers to understand are the significant health disparities that we see with stroke. So, according to the CDC, strokes are highest in non-Hispanic Black adults and Pacific Islander adults. And the risk of having a stroke is nearly twice as high for non-Hispanic Black adults as for white adults. Regarding typology, Chen et al. State that the condition can be progressive if underlying risk factors are not controlled. This is hypertension, diabetes, high cholesterol. So, a 2020 literary review by Greskin Fink on stroke recovery noted that while there have been improvements in treating acute strokes, many stroke survivors continue to face chronic disabilities. CDC reports that more than half of stroke survivors 65 and older experience reduced mobility. It's a leading cause of serious long-term disability in the United States. More from the CDC on symptoms and treatment. Symptoms include ear numbness, confusion, trouble speaking, headaches, loss of balance. And for treatment, time is critical. Patients have 3 hours from the first symptom of an ischemic stroke to receive a thrombolytic. This breaks up the blood clots. But Gresk and Fink report that even with a thrombolytic, clients still experience disabling neurological effects, though they are less severe. The American Heart Association states that after acute treatment, rehab is important, so physical, occupational, speech therapy, mental health support. Preventing future strokes really does depend on medication and those lifestyle changes. Now, let's examine what we as health social workers need to understand to work effectively with stroke patients and their families. First, it's crucial to understand the significant impact that stroke has on family systems. Research by Hughes et al. Indicates that up to 54% of families face relationship challenges following a stroke, with overt conflict in as many as 38% of couples. Stroke often shakes up family dynamics as cognitive and motor deficits make it hard to maintain previous roles and routines. So, as we know from our Carmelli article on unpaid caregivers, they frequently experience what researchers describe as caregiver burden. So, fatigue, anxiety, depression, and even physical health problems. So, at the micro, patient focused level, we work directly with individuals and families. Craig and Bethencourt note that social workers help stroke patients adjust to disability and cope with grief, offering a holistic approach that goes beyond medical symptoms to support the whole person and their family. Here we're looking at resource navigation. This includes helping patients access necessary services and supports for successful transitions, right? They need to go from the hospital to home, maybe to other care settings. We play a vital role in ensuring continuity of care, helping patients navigate complicated healthcare and social service systems. The American Health Association points out that post-stroke depression significantly affects recovery outcomes. No surprise there, right? So, screening for depression is important, but we can also provide education on coping strategies, helping patients and families understand what to expect and how to manage challenges. We can expand on this as we move into the meso practice, working with families, community organizations. In a study by Cheng et al., researchers had caregivers receive psychoeducation, and that focused on problem solving, caregiving, and stress management skills. These participants experienced improved psychosocial well being, and the stroke survivors used less healthcare resources. So, social workers can facilitate support groups for both stroke survivors and caregivers, recognizing the mutual benefit that these connections provide. We continue to work on community resource coordination, addressing gaps in service delivery that leave stroke survivors without support. We coordinate with interdisciplinary teams, right, in the hospital and at rehab settings to ensure family centered care that addresses both medical and psychosocial needs. Finally, let's explore our role at the macro level. This is community and policy, where we work to create systemic change. In terms of advocacy for better prevention programs, we work to develop education initiatives targeting high risk populations, particularly communities of color who we said experience disproportionate stroke rates. We engage in policy advocacy for improved access to preventative care for the conditions that lead to stroke. Remember, hypertension, diabetes, high cholesterol. Social workers want to advocate for workplace wellness programs and awareness campaigns that address these risk factors and educate on the importance of calling 911 immediately. For healthcare system improvement, the Kern et al. Review suggests we advocate for standardized stroke care and performance measures across all care settings, so from acute hospitals to long-term care facilities. The American Heart Association emphasizes the importance of patient-centered care, teams that provide post-stroke management while engaging caregivers and family members. Kern and et al. Point out that Black and Hispanic individuals often receive lower quality post-stroke care and face higher reoccurrence risks than white patients. These disparities are linked to systemic racism. Social workers can help by addressing and promoting anti-racist practices and implicit bias training within the healthcare teams. A major area of our macro level work involves addressing the substantially unmet social needs. A study by Venner et al. Found that 30% of stroke survivors did not receive any form of social support outside of the hospital. Just 11% reported receiving continued support after discharge, while 43% experienced unmet needs in long-term care afterward. Let's look to policy development for health justice. It's critical that we advocate around social determinants of health, like housing, transportation, and food security. Remember, these impact stroke prevention and recovery. We want to expand insurance coverage for long-term rehab services because stroke patients exhaust their benefits before achieving optimal recovery. Social workers can engage in disability rights advocacy, ensuring ADA compliance and accessibility in our communities, even supporting research and data collection on stroke disparities to build evidence base for policy change. Finally, we support community infrastructure by developing reintegration programs for stroke survivors, advocating for accessible transportation and housing, and promoting universal design for disabilities that they didn't have before. We partner up, right, with faith groups, cultural centers, advocacy organizations to build strong support networks. The way I see it, our macro level work creates the foundation that makes micro and meso interventions more effective and accessible. I've got three course takeaways. Two things that I learned that helped me with this presentation were the epidemiology concepts, the social determinants of health framework, understanding how social factors like housing, income, and environmental conditions impact patient health outcomes really helped me to articulate the big picture that social workers bring to healthcare teams. And the other one that helped me with this project was health policy and interdisciplinary collaboration. So the chain of command in medical environments. I now know how to effectively advocate for clients through appropriate channels, helping them navigate the healthcare system to promote patient-centered care. And I like working with older adults. And so, public health insurance system, that was great education for my future. Understanding the distinction between entitlement programs like Medicare and means tested programs like Medicaid will be essential for my future practice.
I'm making this video from my car on purpose. I'm a mobile massage therapist of over 24 years, working with older adults, many of whom are stroke survivors. We work on muscle tightness and spasticity. My clients generally have a support system, and if they're hiring me, they most definitely have funding. I wanted to learn about stroke survivors from a social work perspective, beyond the muscles that I treat.